Good morning. Great to be here. Thank you for having me. Uh, it's always very enjoyable to me to talk to the folks at UCLA. Many of you know that I spent almost a decade at UCLA during my formative years, and I have made a lot of friends, good friends, and I've had really great memories there. So it's great to be here today to talk to you about maxillomandibular advancement for sleep apnea and why does it fail. Now, I'm not going to go over the specifics of this operation since many of you routinely do this operation, but I will talk a little bit about this operation in terms of the history. Um, I want to certainly recognize Dr. Paul Kuo, Roger West, and Dale Bloomquist in terms of as published the first paper on mandibular advancement surgery improving patients with sleep apnea. Um, Dr. Kuo actually trained at MGH where I was trained. I didn't have the pleasure of meeting him. Roger West and Dale Bloomquist have practiced in the Pacific Northwest for many years, and I don't believe any of them are currently in active practice, but I certainly want to recognize them as having the first publications. Now, the first group that linked maxillofacial abnormalities to sleep apnea patients um, was from the Stanford group, Dr. Christian Guilleminault, along with his fellows Andrew Jemison and Mark Rupartnen. They published certainly the close association with abnormal maxillofacial landmarks based on SEFs in patients with sleep apnea. I do want to make a point that just because one may have abnormal maxillofacial landmarks, that does not mean that these patients will have sleep apnea, okay? And vice versa. Just because someone doesn't have maxillofacial abnormalities, it doesn't mean that these patients don't have sleep apnea. Okay, it's just a one variable in evaluating patients with sleep apnea. Over the years, I've always been very interested in not just the operation, but the impact of the operation and how it improves sleep apnea. I published one paper in 2002 using now it's considered low tech, okay, using Ceph and fiber optic airway evaluation with flow meters and standardizing the inspiratory effort in looking at the impact of the airway with MMA. In addition to airway expansion, I found that MMA also improves airway collapse, improves tongue-based collapse, and improves lateral pharyngeal wall collapse. And actually, it is the maxillary advancement that certainly that improves the lateral wall collapse. Lateral wall collapse was talked about by Rich Schwab in that the lateral wall is the component of the airway that's mostly affected by CPAP, and that it is actually the most compliant aspect of the airway as compared to the soft palate and the base of tongue. Now, these are some images from my study in 2002. You can see that on the left, you see the tongue base and the epiglottis and the lateral wall. On the right, it's post-surgery. Post-MMA, you can see that the tongue base was advanced. Okay, the airway is more patent. Um, on these images, on the left is during forced inspiration. You can see that the lateral walls are very collapsible, significant collapse. On the right, at the same patient, post-surgery, in the same inspiratory effort, you can see that the lateral wall collapse was improved quite a bit. Not that it doesn't collapse, but certainly collapse has been improved. Okay. Uh, in recent years, I became interested in flow dynamics and of the airway. So I've done a number of computational fluid dynamic analysis based on CT scan pre and post MMA. You could see that the airway certainly was enlarged before compared to before and after MMA. But additionally, using the computational fluid dynamic and the analysis that you could see significant improvement in the negative airway pressure, okay, before and after in all areas of the airway, along with improvement of the or reduction of the velocity. So I would just say that after MMA, the airflow becomes much more um, peaceful, and it's less quote unquote violent in terms of compared to prior to MMA. It becomes a lot more efficient. Now, in 2022, I published this paper, which is the largest outcome paper on the patients with sleep apnea with MMA. You could see that in this population, mostly were male, 77%, and that their age was about 40 in this group. The RDI was improved by two-thirds, okay, from 39 down to about 14, with significant improvement in patients with severe sleep apnea, RDI greater than 30, went from 55% down to 8.5%. And looking at surgical cure is post treatment RDI less than 5, about 20, 21%. Okay. In terms of surgical success is traditionally defined as greater than achieve RDI less than 20 and at least 50% reduction in the severity of RDI. So you can see that surgical success is about 73%. 73% is not 100%. It's not 95%. Okay. So it's not bad. It's decent. It's pretty good, but it's not spectacular. Now, this is a busy slide. Oops. The busy slide, you could see that when you stratifies um, the based on RDI in patients less than 30, 30 to 60 is greater than 60, you can see as the age increases, the severity increases, the BMI increases, okay? And you could see that the success rate, the surgical success gradually worsens. Okay. And clearly, in older patients, patients who weigh more, patients with more severe sleep apnea, the success rate is less. So clearly, the favorable prognostic factors are patients who are younger, patients who are not overweight, and patients who are less severe. Okay. And I also want to point out that the improvement or the a favorable prognostic factor is based on changes of cephalometric measurement. What does that mean? That means that the greater amount of advancement, you achieve better results. This is a very important point that I will harp on. Okay. Now comparing the first 500 patients to recent 500 patients, you could see that gradually patients have become younger over the years, having less severe sleep apnea while achieving better outcome. So this is looking at the first 500 versus the recent 500. You can see that patients became younger, less severe, and I was able to achieve better outcome. So what happened here? Well, the first 500 or earlier in my career, like everybody else, I followed the Stanford two-phase protocol, right? Phase one is UPPP, or i.e. pharyngoplasty with genioglossus or hyo advancement. And I was looking early on, I was looking at my data and I wasn't happy with what I'm getting. Okay. And that many of these patients did not have sufficient amount of improvement. Some had no improvement. So so I started to offer MMA as a first line treatment. This is, 15 years ago. And that I found that obviously as the data bears out that patients do better, in with the MMA. Now, when do you see failures? To me, there are sort of three main categories: severe complications, insufficient advancement, and occasionally, fortunately, it's not too common, failure despite successful operation. So let's talk about severe complications. This is a paper that I published in 2022 and reported, number of patients that came in for evaluation for second opinion because they either had significant amount of complications or surgical failures. Unfortunately, since that publication, I continue to see the same type of problem. This is a recent patient that I would say that this is the worst complications from MMA for sleep apnea, barring death, that I've seen. Okay. So what happened to this patient? Well, this patient had a number of surgeries and then he had MMA, not by me. And then he contacted me with the following problem. Well, clearly you can see a big hole there, sloughing of the palate. And this is intranasal exam. You can see here's the maxilla, the floor of the nose, sloughing of the septum. This is the inferior turbinate on the right, inferior turbinate on the left. So this is a horrendous complication. Okay. I gave him some suggestions, and somehow he ended up having a tongue flap to try to close this hole. Well, unfortunately, the tongue flap failed. Now, whenever you mess with the tongue, you're going to have speech issues. So this patient in this had the tongue, had the MMA with this problem. He had the tongue flap, which did not take. Now he still has the hole. Now he has a speech problem. On top of that, he has infected graft and non-union. This patient has a long road ahead of him. Okay, so sleep apnea is the least of his concern. I've seen number of horrendous outcomes, as I said. This is a patient that I often show in that you could see that this patient, I think, ended up having at least 7 or 8 operations, multiple operations, non-union, infection, et cetera, et cetera. This patient is on disability. Okay. Now, let's look at my data. I got some heat for publishing, patients with severe complications. So let's look at my experience. I went back from 2022 and went backwards and reviewed 200 patients in looking at, complications, specifically infection, hardware failure, healing problems, et cetera, et cetera. So in this group, the mean age was 31, range 17 to 66. I do want to point out that I'm not enthusiastic in offering surgery in patients who are older than 60. Okay, this 66-year-old was really struggling as a woman and just tried everything and really struggling. So I agreed to do the MMA on her, and she did quite well and was happy with the outcome. But by and large, age is an important factor in terms of my decision in offering MMA. So you can see that 194 out of 200 patients had one single operation. No hardware removal, no nothing. Okay, one operation and done. 6 patients out of 200 patients have had to uh, be brought back to the OR. Okay, what are they? I mean, what are the reasons? One patient um, had displacement of the maxilla. Now, this patient has had bipolar. Okay, and during the liquid diet phase, the medication was not well managed. So the patient developed a manic episode. And shortly after surgery, went to the gym and thought that he could bench press a much heavier weight than he usually could. So the weight, the bar fell on his face and displaced the maxilla. So these are rigid fixation, but then they're not that rigid against, a heavy weight. So the maxilla was displaced, and I had to bring him back to fix his maxilla, and that was fine. 5 patients developed some localized sort of loose screws or loose plates or what have you. They require removal. So one patient had maxillary plate that had to be removed. Four of them had mandibular plate or screw that had to be removed, and all were managed with just simple hardware removal and res had the localized infection or what have you that uh, without needing anything beyond that, just simple oral antibiotics and hardware removal. Okay, zero osteomyelitis. Zero patients out of 200 that require IV antibiotics, zero non-union, zero malunion. Okay. Well, let's look at from the same institution, published by Riley in 1997. I started there in 1996, 1997-ish. So this is sort of data before my time. He reported 182 patients with maxillofacial surgery, meaning in addition to MMA, there were genoglossus advancement and hyo advancement, what have you. Okay. And you can see that's mean age about 48, mostly male. Um, there were specifically 16 MMAs. Let's look at the 16 MMA. Out of 16 MMA, one had localized infection treated with local wound care or antibiotics. Okay, so no osteomyelitis, no IV antibiotics, no non-union, no malunion. Okay, so I would say from an institutional standpoint, this is fairly consistent data, right? Now let's take a look at across the, on the other side of the coast from Lenny Caban. This paper was published in 2015. He looked at 25 patients with MMA for sleep apnea. Um, Interestingly, he had one patient that required revision surgery due to facial trauma. Okay, it's after surgery, the patient had facial trauma, similar to my one case, and had no non-union, no malunion, no osteomyelitis. And they reported that with large advancement, all these patients had about 10 millimeter advancement over a 2-year period. The advancement was stable. Okay, so now everybody talks about 10 millimeter advancement. Where did it come from? Came from, well, here. I've been talking about approximately or at least 10 millimeter advancement for, you know, my entire career. Riley published on it. And when you look at my publications over the years, you can see that the advancement gradually increased. Okay. And what's the difference? Well, back in the days, we're just advancing the jaw straight. Okay, trying to improve patients who are quite sick. Now, over the years, with improved fixation, with virtual surgical planning, and with counterclockwise rotation, et cetera, you could improve the aesthetic outcome while achieving a greater degree of advancement. Remember, I mentioned that the extent of advancement is uh, a very important prognostic factor. Now, if you advance someone insufficiently or a small advancement, your outcome is going to be not as good. Okay, so I've seen many patients that came for second opinion due to insufficient advancement, and they continue to struggle with sleep apnea. You don't need a ruler. There's a ruler right here. This is 5 millimeters. I always look at the mandible. Okay, just a saw cut is 1 millimeter. So this is what, a 2, 3 millimeter advancement. Okay, that is not enough for sleep apnea. I do want to make a point of the genioplasty a little bit. So one example, another example. Okay, 5 millimeters maybe, a big genio. We'll say 5 millimeter with a genio, you know. So I do want to take a minute and talk about genioplasty. This is a genioplasty. Everybody tells me, and everyone talks about, oh, genioplasty improves sleep apnea. Where did it come from? Well, it derived from, back in the early 80s, Christian Guilleminault and Riley, they published a paper on that the hyoid position in patients with sleep apnea is lower. Okay. And the correlate, because back then people really just did UPPP mostly. So it linked the tongue-based collapse, tongue-based problems in patients with sleep apnea. And hence, so basically the looking at the higher position and Ceph and all that, it's all from the originated from the Stanford group. Okay. Now, operations were developed to try to quote unquote normalize or advance the tongue base. So on the left is the genioglossus advancement. You can see that it captures the attachment of the genioglossus muscle. Okay, well, with advancement of the geniotubercle on the left, and you can see that the hyoid sort of advancement or suspension to try to advance or rotate the base of tongue forward to improve the airway. This is a cadaver dissection showing that on the left, there's a genioglossus muscle. When you pull it forward, advance it, you could tighten the tongue or tighten the genioglossus muscle to limit the retro displacement or collapse of the tongue for sleep apnea patients. Okay. Certainly, it makes sense. It makes anecdotal sense. Okay. But I also want to point out that the genoplasty does not capture the geniotubercle. So the two operations, this is a geniotubercle advancement with the genioglossus advanced. Now, these two are different operations. And I will say that when I look at my result, this phase one surgery, pharyngoplasty with genioglossus advancement, you can see, hey, the Ceph looks great. Wow. Look at the airway. Look at the advancement in the geniotubercle and the pharyngoplasty. Well, these patients did not improve. Same sleep apnea results, same PSG results, same symptoms. Okay. So that's why I just stopped doing phase one surgery because sometimes it improves, sometimes often it doesn't improve enough. So clearly, conceptually, wow, if you have advanced the geniotubercle, you're going to tighten the tongue. Yeah, that sounds good. Well, if you do a genioplasty, you advance the attachment of the geniohyoid, the strap muscles, the suprahyoid muscles is going to tighten the tongue, what have you. Yeah, it's all sounds good, but it's not good in reality. There's just no good data. And all these people that are doing this operation claiming that it helps, I would like to see the result because there is no result. Okay. A lot of people can disagree with me, which is fine. I'm not always right, obviously, but show me some valid data. Okay. And again, just because something sounds that it works or it makes sense, let's take a look at the data. Okay. One other thing for the residents, make sure that you reapproximate the mentalis muscle. Okay. I've seen a number of patients with mentalis muscle dysfunction, meaning you could see that the lower lip becomes kind of incompetent. It achieves insufficient amount of lip elevation or lip closure, and they show the lower teeth excessively. They have problem keeping food and water inside their mouth. So and I've tried to repair a number of them. It is the outcome is not good. Okay, so the time to make it right is at the time of the surgery. So let's get back to insufficient advancement. This patient came to see me long ago. You could see, just look at it, about a 2 millimeter on the left, 3 millimeters on the right. This is not a good MMA for sleep apnea. Now, I've been doing revision MMAs in my entire career. This is in 2000s. Okay, this is not my genioglossus advancement. This was done by the original surgeon um, after his MMA. Okay, so you could see that revision MMA. This was early on, so you could see that jaw was just basically all had to cut through all these screws. This is 2000, 2010, same. Had to do revision MMA for insufficient advancement. 2020s, same. This patient had what, a 3 millimeter advancement for his sleep apnea. Then he tried Inspire, try also. Then I have to, have to advance it because he continued to be symptomatic. Now, whenever I do a revision MMA for sleep apnea, this is what I tell patients, or any revision MMA. One is twice as hard. Two, twice the complications. And a lot more difficult, and the advancement is not as good as if you had a good primary MMA because of the scarring and it's just harder to advance, etc. That's why I keep on harping about sufficient advancement for sleep apnea. Obviously, it's a given that you have to make sure that the aesthetic is good. Okay. Sometimes you have complications and you have insufficient advancement. This is a patient that came to see me actually prior to his MMA, and we talked about options. He elected to have MMA elsewhere, which is fine. But months later, he came back to see me because he had nowhere to turn. He had MMA. What are his complaints? Number one, he doesn't like the way he looks. So this is the profile. This is the profile. So you could see that aesthetically is not a great advancement. Okay. It's not a whole lot of rotation, and he still has a deep eye, blah, blah, blah. So he doesn't like the way he looks. His lower lip is at least 50% numb, quite a bit of numbness bilaterally. Okay. He still has the same symptom, not much improved at all. And worst part is that his upper teeth 24/7 has this buzzing sensation. It's there all the time. Okay. So this was the plan. That's the amount of advancement. Not enough for the treatment of sleep apnea. Okay. Sure, people talk about custom plate. I don't, no amount of custom plate is going to be able to help this patient. Okay. I'm not going to talk too much about custom plate. Custom plate is fine. Depends on your preference. So this is, he still, oh, by the way, he still can't breathe through his nose. Obviously, he has severe septal deviation. Is this patient a candidate for revision surgery? Is this patient a candidate for nasal surgery? Is this patient a candidate for nasal max expansion? Yes, but I did not offer anything because I was concerned of his sensation of buzzing, buzzing sensation of his upper teeth and jaw 24/7. Additional surgical trauma can worsen this problem. So I sent him to a neurologist. Hopefully, with a tincture of time, this will improve. I don't know. So, is this a MMA failure? Absolutely. Okay. So I keep on talking about, oh, insufficient advancement. What do? I went back to 2022 and went back. These are 10 consecutive MMAs, okay? They're consecutive because I want to be realistic. These are not cherry picked. Otherwise, I would have picked prettier pictures, okay? So that's the extent of advancement that I do. You can see no genioplasty, okay? That's the advancement, okay? You can see the gaps yourself. The advancement extent is different, but none of them are limited are small advancement. And genioplasty. Do I do genioplasty all the time? But what's the indication? Aesthetics. I do number of chin lengthening for aesthetics. Okay. You can see the degree of advancement. These are good advancements for sleep apnea. Okay. Even with that, even with the way that I advance patients, my success rate was in the high 70s. So can you imagine with those other CTs that I've showed you with limited advancement, what that result could be. So even with the way that I plan and advance the patients with the MMA, this is the result. Okay. Let's talk a little bit about failure despite a successful operation. Now, sleep apnea is complicated. It is not nearly as simplistic as, oh, this patient has, based on CBCT, the airway volume is X, or normal is Y. Uh, this just sounds so, uh, I don't want to say it, but it sounds so idiotic. There's no quote unquote normative data. Okay. And oh, this patient's SNA is 76, normal is 82. Let's normalize the SEP. I mean, what are we doing? That you know, please don't be a technician. Just it's not a cookbook. You have to look at all different patients. Okay. But on top of that, the sleep and airway, it's very complicated. Some I have done big MMAs. Like you've seen the CT scan. I've done MMAs and I have had patients, rare, fortunately, that there was no impact with a good, 14, 15, 16 millimeter advancement, had no response. I have also had MMAs in rare patients where after surgery, they felt great. Okay. In 3 to 4 months' time, they relapsed to baseline. These are rare patients, but they have these patients. This happened to me. Okay. So I want everyone to know that it's, when they see a case like that, it's, the airway looks great, but, the advancement was great, but no improvement. That's why I tell every patient, this operation is not a guarantee operation. Now, why does it happen? It's not always just the advancement. Oh, we're going to make the airway X is going to be, you're going to be great. It's not always that case. It's due to abnormal. I think it's basically it was sort of it's the neuromuscular relaxation that we can't control. Now, because I had these occurrences, I was just really interested in what is going on with the airway. Along with Christian Gimeno, we looked at, looking at sensory responses on 2-point discrimination on patients with sleep apnea compared to patients with control and normal control and URS patients. Patients with sleep apnea have impaired palatal sensory responses. Well, is it just um, is that one of the cause? Because I'll go into that. It's from the brain. It's from the brainstem. Okay, and other authors have looked at that the sensory impairment involves an entire airway, the laryngeal, oropharyngeal, velopharyngeal area. And looking at the paper at the top, 1998, published from Europe, they looked at repetitive snoring or collapse that injures the upper airway muscle. Okay, and the muscle injury is correlated with the extent of obstructive breathing. So, and we know that the airway caliber is altered in patients with sleep apnea, but the airway caliber is determined by the brainstem, afferent sensory input to the brainstem and the respiratory center, et cetera. This was sort of review published by Dr. Gimeno in 2009. We've known this. So it's not just making the airway larger. There's some, there are some patients where they're wired a little differently. Okay. Unfortunately, I wish I could identify them prior to MMA, but I don't know how. So what do I do now? What do I do in patients with sleep apnea? This is a very good teaching case, so I'm just going to show this case, okay? Um, she's a 27-year-old, mild sleep apnea, RDI about 10, but has multiple awakenings at night, very tired, wake when during the day. She used CPAP not very effectively, and she's symptomatic. She was symptomatic, and she came in to see me already basically orthodontically prepped already for MMA. Okay. So she elected to have me do her MMA. But so what comes to my mind when I first see her? Well, first, aesthetics, right? Well, everyone's focused on aesthetic as well as they want to improve their airway and what have you. But she's Chinese. For obvious reason, I was very interested in sleep apnea in Chinese. Not just because I'm Chinese, but also because over the years, I've seen young, healthy, non-overweight Asians, often Chinese, with severe sleep apnea. I'm talking about AHI in the 50s and above. Okay. It just doesn't make sense to me. Initially, I thought, early on, this is back in, 1999 or in 2000, I thought it was only the airway, but it's not just the airway, not just plumbing. Okay. So, I found that Asian men tend to be, or they tend to be less overweight, but they tend to have more severe sleep apnea. Okay. And I also did some CT scans and looking at Asians and what have you, found that the retropelvic airway area is actually is more sort of quote unquote compromised compared to controls or snore people who don't have are simple quote unquote simple snorers versus patients with sleep apnea. So the Asian airway is a little different. Okay. And in this patient, going back to this patient, so obviously Asians, in my opinion, a little harder to treat. That's the first thing that came to my mind when I saw her. Uh, Second, looking at a CPCT, well, you could see that she had fair amount of condylar resorption. It's in a stable status. Now, I expect some surgeon will say, "Oh, automatic total joint replacement." I've treated many patients, did jaw surgery on patients that with joints look like this. To me, I'm not a big fan of total joints, but that's subject to debate. Not that it doesn't have its place, but this patient was doing fine. Minor TMJ pain occasionally, but everything was stable. So I offered to do her MMA. Okay. Now, aesthetics is always important. Okay. So nowadays I develop 2 to 3 plans. Okay. And I go over the pros and cons of each plan with the patient. So at the end of the day, the patient will decide what he or she elects. This was the 2 plans that I presented to her. You could see that, she's a young woman, non-overweight, obviously, and it's a decent advancement. This is really focused a little bit more on aesthetics, yet improving the airway. This is more focused on the airway. Also, the aesthetic is certainly important, and that I do not think that the aesthetic will be very much compromised. But this one really is to focus on the aesthetics while achieving the airway improvement. Well, she picked plan A because she wants to make sure she doesn't look bad. So this is before and after surgery. I think the right is, I don't know, 8 months out or something like that. Okay. Now, one thing to point out, so you could see her chin morphology. Well, because of the significant amount of mandibular deficiency and she had fillers injected into her chin. So you could see over time and had to kind of gauge or guesstimate how much of the resorption of the filler is going to take place. You could see that the chin morphology looked definitely better after the fillers dissolved. So, getting there, you could see soft tissue chin. You could see that it's reduced, 2-3 millimeters. So I had to make sure I sort of hit that because at the end of the day, it's not the bone; it's a soft tissue chin that's going to determine the aesthetics, right? So you could see this is before. This is I think 2 months out, something like that, and this is about 8 months out. You could see that the tightening of the tissues and all that. So she was happy with the aesthetics, and her sleep improved significantly. Okay, you can see rotation and all that, which everyone knows. Well, she's much improved, but she still has some symptoms. Okay. And she came back because she still has some symptoms and still wakes up occasionally and she wants to see what else that I can do for her. Well, I corrected her deviated septum because she does have some nasal obstruction and she's getting allergy shots. Okay. And I expanded her. You can see this is a skeletal expansion. And you can see that this is skeletal expansion without any arms to the teeth. And now I do want to make, so her breathing is better, her symptoms are better, but she wants to now maximize her expansion. Well, it's going to be an issue in terms of managing her expansion, try to improve it. I do want to make one point. People say, oh, yeah, you're going to do the expansion and that the all the tissue is going to swell and that it's going to counteract your expansion. First of all, this is called nasal cycle. Okay, turbinates, they alternate and all that at a certain period of time. Number one. Number two, the turbinates that swell up is only the inferior turbinate, not the middle turbinate, not the superior turbinate. The makeup is different. Okay, nasal maxillary expansion expands the entire nasal cavity. So even with some swelling on the inferior turbinate, the maxillary expansion achieved a significant amount of nasal expansion, improvement of breathing and sleep. Okay. Now, with her, I did actually did MSE. Why? Well, no, just short, briefly. I use all different devices. Okay. Ease is what I do. Ease is an operation. It's not married to any device. I use four different devices. Uh, how I choose them depends on age, gender, anatomy, and objective. I'm not going to go in, this is beyond the scope of this talk. But, you know, I chose MSE because after E's, she's a young woman, she'll be easy to expand. So it's just basically just skeletal expansion with MSE. And you can see that this is the MSE. You can see that jaws was widened with the MSE, but very little diastema and the bite was, needs some ortho, but not grotesquely wide. Okay. Skeletal expansion before, right after MS, you could see the osteotomy and you could see the total sort of posterior and anterior expansion. Okay. Before MMA, after MMA, you could see skeletal expansion with the MSC. And she's better and she's hoping to keep on expanding, but I need to sort of manage in terms of her bite, making sure it's not too wide. And she said, blah, blah, blah. All right. Now, I want to conclude by saying a couple of things. Number one, in addition to the 1,000+ MMA now, I've done a lot more routine orthodontic surgery. So comparing the complications, you know, MMA for sleep apnea does not have a higher complication rate. Okay, just based on my data. And large advancement, the advancement is stable. It's not just my experience. Others have published on it as well. Genioplasty, I'm sorry. Show me the data. It is not it's you want to do it for aesthetics, fine. But I don't think it's a good operation for sleep apnea. So lastly is that you could see, sleep apnea is not simple. It's a complicated problem. And you have to understand sleep. You need to know the data. And in order to present good treatment option, realistic treatment option for patients. It's not just about, taking a CPCT and looking at the colors, of the airway, et cetera, et cetera. Be a doctor. Don't be a technician. It's not this simple. You have to learn it. Okay. I'm going to stop here and I appreciate your attention. Again, it's a pleasure to be here.